Hello, good evening. This is chapter 1, topic 1 of our health service system, and this is the introduction. Okay, so the objectives for today is to define health service system and discuss the transformation of the health system. So the question is, what is a health service system? It is an organization or institution and resources whose primary purpose is to improve health. So a health system needs staff, funds, information, supplies, transport, communications, and overall guidance and direction. And it needs to provide services that are responsive and financially fair with while treating people decently. So, the public health sector um, has rural and tertiary. So, uh, the rural health, the first public health, this is one of the largest sector in the services department, whereby the government provides almost all the infrastructure and human resources, while the tertiary on the next one, the number two, is notwithstanding these problems, and the past 5 decades have seen the Malaysian healthcare structure remaining quite well integrated. So, purchasing corporate expertise or purchasing private sector expertise is migration of trained staff, especially medical specialists, to the private sector in order to continue to bug the system, which then causes expert service to stall because the requisite expertise had been lost. So, full paying patient is defined as, or the FPP scheme is defined as where part of the fees were used for physicians' reimbursement to supplement their income or allowance. Thus, this scheme provides those who are willing to pay more quicker access and shorter waiting times for elective surgeries and other therapies. That's one of the definition. So another definition is the private health sector, which is the private sector on the other hand that has always attracted both general and family physicians who had opted out by opening individual clinics or by joining more established group practices, while specialists join the better paying, more personalized care practices in urban private medical centers. So the number one on the private health sector is the general practitioner clinics. What are those? Those are importantly nationwide private clinics that cater to most of the fee for service self paying public, which include the private sector employees through panel doctor contract or insurance arrangement, and relieving the already overloaded Ministry of Health's public clinics. So those are the general practitioner clinics. The private medical centers and hospitals for more serious illnesses and injuries are the hospital care through well equipped emergency departments and is now the expected practice. These medical emergencies are previously offered only at larger public sector general or district hospitals. So, private healthcare facilities and Services Act regulations are currently the Private Healthcare Facilities and Services Act, or PHCFSA. This is a very big um, policy and regulation that have prodded the private sector to transform for better, pur- purportedly for safeguarding the safety of patients. But forced administrative micromanagement still finds and restricts have angered many private medical practitioners. Remember that there are policies on private healthcare facilities. If you just want to make some private healthcare facilities, you have to go through the PHCFSA Act or regulation PHCFSR. So, healthy individuals and communities are very important for health service system. That is one of the major goal for health service system. As you can see on that box, wellness focus, person focus, informed person, self help, care provided at home, close at home are all about healthy individuals, families, and communities. And seamlessly, continuous care, services tailored as much as possible, and effective, efficient, and affordable services are also for the healthy individuals. So, towards health system transformation, what do we do on health system transformation? So, challenges now, and many more challenges. There are a lot of challenges here um, for the rising of healthcare costs. There's so much expensive medications that needs to be procured, but it seems that they cannot procure it. So private and public health resources imbalances are also one of the challenges. And the rising of non-communicable diseases such as diabetes mellitus, obesity in Malaysia are all one of the challenges on healthcare institution. So the national health system transformation, it is a restructured national health system that is responsive and provides choice of quality healthcare, ensuring universal coverage for healthcare needs of population based on solidarity and equity. And therefore, they have devised this component that is service delivery, financing, organizational, and they are more into the agenda of the national health system transformation. They want to transform from strengthening the current health system to the public facility autonomy in the primary healthcare reform until the hospital reform and fully implemented transformation. So that is basically our introduction of health service system. We have discussed all the terminologies and all the policies that is necessary for you to build your own health service system for your public health need. So we will continue on the next topic. So, welcome again to the second topic, which is the medical care process. And this is the second topic that we're going to discuss, and it's all about medical care processes. So, the objectives for today on this topic is to discuss the terminologies on health service system and discuss various types of healthcare, okay, and discuss the process of care improvement. So the overview of health status, the definition of health is a broad definition of health. So what is health? What do you mean by health? It's proposed by the World Health Organization in 1948. It has been repeated and purportedly for many years. It's the complete physical, mental, social, emotional, and spiritual well-being, not merely the absence of disease or infirmary. Okay, that's the World Health Organization's definition of health. And general health status should have the life expectancy with international comparison, and healthy life expectancy, years of potential life loss, YPLL, with international comparison, physically and mentally unhealthy days, self-assessed status, limitation of activity, and chronic disease prevalence. Those are the general health status that is necessary for you to look at the health as overview. So life expectancy is defined as the average number of years a population of a certain age would be expected to live, given a set of age-specific death rates in a given year. So the World Health Organization gave a life expectancy of 78 years old up to 77 to 78 years old. Sometimes we will reach it to 87, 88, 89. That's way past your life expectancies. And international comparison of life expectancy, the healthy life expectancy is the average number of healthy years a person can expect to live if age-specific death rates and age-specific morbidity rates remain the same throughout his or her lifetime. That means there is a comparison of life expectancy from the life that you're experiencing right now. So years of potential life lost is a summary of measure of premature mortality, which means the early death, premature, before you potentially reach the age of expectancy. And therefore, that is what you call the YPLL. It's a premature mortality. YPLL is based on the number of deaths at each age up to some limit. So, the years of potential life loss by cause of death, YPLL, can be calculated as death from all causes or cause of specific measure from death, or death from motor vehicle accident, or are the second leading cause of YPLL for both genders. So, the physically mentally unhealthy days measure the number of days passed in 30 days that individual rated their physical or mental health as not good. And physically unhealthy days increases with age, and mentally unhealthy days also decreases with age. So, those are the physically and mentally unhealthy days. Self-assessed health status. The self-assessed health status is measured of how an individual perceives his or her health, rating it as excellent, very good, good, fair, or poor. So, what is your self-assessment of your health? And self-assessed health status varies by age. It doesn't mean that you are unhealthy because uh, you are not healthy, but maybe because your age is already getting higher. Limitation of activity refers to a long-term reduction of a person's ability to do his or her usual activities and activities of daily living, instrumental activities of daily living, and play, school, or work are limitation of activity. Remembering is also a limitation of activity when you have Alzheimer's or dementia or whatever form of dementia you have. Those are the remembering limitation of activity. Any other activity they cannot do because of limitations caused by physical, mental, or emotional problems. So, chronic disease prevalence are the leading cause of death and disability in the United States, causing 7 out of 10 deaths per year. Heart disease, cancer, and stroke alone causes more than 50% of all deaths each year in Malaysia. So those are the chronic diseases. And Medicare is the maintenance or improvement of health via the prevention, diagnosis, and treatment of disease, illness, injury, and other physical and mental impairments in human beings. Healthcare is delivered by health professionals, and therefore it is systematically provided by personal and population-based preventive, curative, and rehabilitative care services. What are the various type of healthcare? Number one is the primary healthcare. We have this primary care, the one that we do personally, the secondary care, the tertiary care, and the quaternary care. So these are the various types of healthcare. So the primary care refers to the work of health professionals who act as a first point of consultation for all patients within the healthcare system. So you are the first point, you're the primary care. Such a professional would usually be a primary care physician. Okay, such a general practitioner or family physician are primary care providers. Secondary care, it includes acute care and necessary treatment for a short period of time for a brief but serious illness, injury, or other health conditions like in the intensive care. This care is often found in hospital emergency department when you have the emergency care that you need. The secondary care also includes skilled attendants during childbirth, intensive care, medical imaging services. Those are the secondary care. The tertiary care is a specialized consultative health care, usually for inpatients on referral for a primary or secondary health professional in a facility that has personnel and facilities for advanced medical investigation and treatment, such as a tertiary referral hospital. So the quaternary care is sometimes used as an extension of tertiary care. This is just an extension of tertiary care if you want to extend it, in reference to advanced levels of medicine which are highly specialized and not widely accessed. Experimental medicine or quaternary care, you know, when you have clinical trials, you've never done this before, you want to experiment, it's never proven, those are quaternary care. And some types of uncommon diagnostic or surgical procedures are considered as quaternary care, or clinical trial, double-blinded trials, something that you wanted to experiment on, it's never been tried upon, and those are the quaternary care. So, the care process improvement on the most general level of all healthcare can be conceptualized as a system involving two fundamentally different core processes: care planning and processes, care planning process and care delivery processes. So those are the care processes. Care planning processes involved a clinician working with a patient to determine which, if any, healthcare interventions should be pursued at a given point in the patient's care for each of the health problems facing the patient. That's the care planning process. So let's see the care planning process. This is an illustration of the care planning process. As you can see, uh, the best practice here are the literature and expert opinion. That's the best practice. And then the care planning process goes forward to care planning, care delivery of health. That's the healthcare. And then you collect the data of what you have, and then you analyze the outcomes. And then uh, you check the data of your outcome, and you see the quality, the quality of cost and performance analysis, and then benchmark or see the goals if you have achieved the goals of what you're trying to benchmark. And this is another illustration of the care process where the literature review and the experts' outcome opinions are the best practices. And then comes to the care planning and healthcare delivery, onto the implementation of the processes and the guidelines and the protocols, going to the incentive and feedback. You know, the feedback, the patient satisfaction feedback, and the performance. This is more of a benchmark performance analysis, and the quality of cost is there, and the outcome are measured as well. So, necessary elements of care management initiative are found here. The conducting of a preliminary need assessment or problem identification, and establishing the appropriate improvement team, defining the target population, identifying measurable goals and objectives, articulating the desirable decisions, and decision making care processes. You know, you have to decide on the care that you want to deliver, and then designing a plan for implementation and developing means for ongoing monitoring. So the utilization of services um, is the actual coverage, and it is categorized into ambulatory medical care services or outpatient and home, and the inpatient services or the hospital, and preventive services. To achieve optimal levels of utilization, all the three categories must enlist the cooperation and initiative of the population as well as those of the health service providers. So this is WHO model of healthcare utilization: to collect, assess, plan, implement, and follow up. It's a World Health Organization model of healthcare utilization. You have to collect the data, assess it, plan your care, implement it, make sure it's been delivered, and then follow up, monitor, or evaluate. So that's the end of our session number 2. So thank you very much, and I'll see you again on session number 3. Hi, this is session number 3. Welcome again, and this is the workforce issue. So the objectives for today is to discuss strategic workforce planning and discuss health service workforce. So there are three key issues as drivers for strategic workforce planning. First is the organization's strategic plan, and then the next is the workforce changes brought about by factors outside the organization's direct control, and demand for workforce maintenance and enhancement. So, the strategic plan, the workforce issues uh, tied to changes in strategic business plan and other new business initiatives. Example, change in business model and creation of new business line, and then the reorganization of businesses and new agency performance standards. So they have the standards of performance as well. These are the 4 issues tied to changes in strategic business plan and other new business initiative examples. So the changing external environment is the workforce issue brought about by anticipated changes outside the organization's direct control and influence. Examples are the labor shortage, the budget revenue shortfalls, or the budget cuts, when they cut off the budgets, changing workforce demographics, like the workforce that they want to change, like the age, or sometimes in BMI they change it, they want lower BMIs, and sometimes the demographic of gender, they only want male or they only want female, or sometimes they only want those within the reach of the location, geographically, demographic the demographic geographical locations where they live. That's what they're looking for sometimes. And governor legislature mandate is also a changing external environment. Those are the workforce issues. So the maintenance and enhancement are issues, and they have issues related to maintenance of risk management for an improvement to the existing workforce. They have anticipated retirement bubble. Okay, they have regular training required. Those are the maintenance enhancement. They have performance planning cycles and business continuity planning. So the issues driven by strategic planning, these are the strategic planning. This is one of the most important but often overlooked starting points for developing workforce plan. And issues driven by changing environment have many workforce issues that are caused by changes in the market labor pool or legislative actions. The driven changing environment. External environmental scanning, assessing the external environment, you may have to assess the external environment, involves a process called environmental scanning. And common external factors that influence workforce planning includes changing the population and workforce demographics, client citizens demographics, expectations and perceptions, the partners and suppliers, political and regulatory environment, and the revenue systems and budget appropriations. So the issues demand for workforce maintenance and enhancement have employers often focus first on issues with existing workforce. And these issues involve maintaining the workforce, managing risk, and improving quality and performance. This is the workforce that you use, the manpower, the people who work for you. Maintenance issues deal with the staffing levels and sustaining employee knowledge and skills. That's why they send you all for training and they send you all for more skills development. Risk management issues deal with workplace safety. If your place is full of infectious diseases, sometimes you have to be safe with yourself. Vaccinate yourself, protect yourself with personal protective equipment, limit the visitors, make sure that nobody comes in if they're not nobody comes inside your workplace if they're not invited without any schedules, and liability employment and business continuity following a critical incident. Critical incidents such as the pandemic, that's a critical incident. So common internal capacity factors that influence workforce planning include workforce demographics, major job categories such as age, race, gender percentages. It's also a workforce demographic. They are planning common internal capacity if you are on that common internal capacity. Staffing levels, general turnover, and anticipated retirements. When you're anticipating retirements early, then you don't need to get those people. Sometimes they love people who are retired. The workforce loves them. Internal candidate pools, develop candidate recruiting programs, and screening and selection strategies. Current projected internal workforce competency requirements such as knowledge, skills, abilities, and behaviors. Program performance standards such as goals and outputs, and employee performance standards of goals and outputs. So, in continuation to this, the organizational design, superior span of control, centralization versus decentralization, and distribution of specialists and generalists are one of the organizational designs. They have centralized, decentralized, specialists, generalists. Those are the organization. Workforce distribution, such as location and travel requirements, they are distributions. workflow, method, and processes, and human resource systems such as compensation, classification, work rule and policies, collective bargaining agreements, and performance management strategies, and organizational value and culture. Employee satisfaction and engagement levels is also one of those designs. And the tools and the resources, do you have the materials? Do you have the capacity to run this with your workforce? Do you have the resources? So health service system workforces are the next interesting topic, and we will discuss in this issue. First is the physician. Very important is the physician because they're the ones who can legally sign all those insurances, and the shortage of them, likely given current levels of medical education and training, are the reasons why there are shortages. And education and training, even with a substantial increase in medical education and training capacity, it's likely that all of the increased demand for health services can be met by a physician. So on the demand side key factor, the expected shortage of physicians is driven by likely changes in the supply and the demand for the physicians. On the demand side, key factors include the population of the United States is growing rapidly. The largest growth will occur in the group people over the age of 65, and those who consume the greatest health care resources, and the expectations and wealth of sometimes the Americans will motivate and enable them to use more healthcare services. And sometimes this is not just the Americans but also the Malaysians and other Europeans and other Asian countries. On the supply side, key factor includes one third to 250,000 of active physicians over age of 55 years old and likely to retire by 2020, 2022, 2023, 2024. The newest generation of physicians is unlikely to be willing to work the long hours. You know, they are so young, they have a lot of potentials, and more likely we have over age 55 who are willing to work that kind of long hours that prior generations of physicians reportedly work. And medical assistants, on the other hand, in almost all healthcare settings, medical assistants undertake roles which are not of their forte. Hence, they are left with minimal time to carry out their actual roles and responsibilities. This is what they're this is what they're trained for, and then they're given multitasking. Many medical assistants now are getting promoted to high management faster than other healthcare professionals, and there are shortages of clinical medical assistants in the Ministry of Health. So many medical assistants are very necessary, needed. In the late 19th century, which hospital operated training schools provided patient care and combined nurses education with nurses employment in the same body of workers. And student work in the hospital learning the nursing procedures that particularly institutions provided for their patients. They are also working for because of the lack of staff nursing. So the challenges faced by medical assistants at workplace are mental violence. You know, sometimes they're being harassed mentally, shortage of staff. Now there's a burnout, workplace health hazards, exposed to a lot of infectious diseases, long working hours because multitasking, lack of synchronicity. They don't know how to synchronize their timetable. Sometimes they overlap things. Lack of recognition. Even though they work hard, they're still not recognized by monetary recognition or any forms of recognition. And non-clinician roles, they're being used for non-clinician roles as well. And workplace violence is widespread in healthcare settings, in all healthcare professionals, for all healthcare professionals. And it is widespread in healthcare settings that huge amount of workload and responsibilities on the staff can often lead to disturbed mental peace, which will ultimately lead to less efficient care. In a healthcare setting, the possible sources of violence include patient visitors, intruders, or even your own core workers. So the shortage of staff is an issue as deficient manpower leads to unmanageable patient loads and patient ratio. Patient ratio needs to be well maintained, especially in the intensive care or in emergency care, to be well maintained as it is highly affecting the patient care delivery system. That is the shortage of staff issue. And workplace health hazard confronts a risk of developing occupational health which of if not taking proper precaution and care, it will be confronted with a variety of biological, physical, and chemical hazards during the course of performing the healthcare duties. Long working hours, this is going to lead to burnout, and shorting staff pattern in healthcare unit often results in long working hours and double shift of staff. It is evidently affecting the health of the staff, and they are becoming burnout or stressed out. It's quite difficult for a medical assistant to provide efficient care with exhausted state of mind and body. So lack of synchronicity, disharmony, and lack of teamwork is an emerging challenge in the healthcare sector. Harmonious relationship amongst healthcare workers is an essential requirement for the healthcare system. Bear the indirect opprobrium of every dreadful incident in which occurs in the hospital. The lack of recognition, hospitals must be safe place for sick folks and their medical services, carrying out responsibilities that are not always recognized. And there is no support system sometimes for healthcare workers. Hence, their performance are usually not projected well. So the non-clinician role is the changing demand of the healthcare sector in middle income countries. Low and middle income countries continue to challenge efforts to address critical shortages of the health workforce. Addressing these challenges have led to the evolution of non-clinicians, and they can assume some physician roles and thus mitigate the continuing shortage of medical professionals such as the doctors. Non-clinicians are generally as being healthcare worker with fewer skills than physicians that have more skills, and this is an interesting definition such as the administrative officers, the clerks, the clinical assistants. Okay, those are the non-clinicians, and that they assume a common goal, global scope of practice, and an absence of varied skills range that each cadre may gain through additional and specialized training and gain experience in other development activities. So that's basically the topic for today, and thank you very much for um, uh, watching topic number 3. So I'll see you again in the next topic. Bye. Hello. Welcome to topic number 4. This is facilities and programs. As you can see, they are having programs and facilities here. So what we're going to discuss here is the facilities and program, discussing the facilities and program, and discuss necessity of integrated care, and discuss healthcare financing. So facilities and programs of healthcare for patients and their families can assure quality of care, and it has been established to ensure facilities provided healthcare services in a clean and safe environment that meets their physical, mental, and social care or social needs. Feeding program is very famous on all healthcare community, and vaccination is also a program for all clinics in Malaysia, especially for the pandemics, for the ongoing pandemic nowadays. And in order to have the Malaysian healthcare mainly under the Ministry of Health, it has to have an efficient and widespread system of healthcare operating a four-tier healthcare system consisting of both a government-based universal healthcare system and a co-existing private healthcare system. So this is the four tiers of the government. They have the public and the private. First of all, this is the public, and that's the private, and they are divided further into subcategories. Okay, this purchaser, provider, and the coverage, and then they have the local taxes, government general revenue, the SOXO or the fund, provident fundings, and other maintenance and departments of hospital clinics and doctors. They have the private of the employers and the individuals with private insurance agencies or group managed care outcomes. So the private providers can have the general practitioners, the dentists, the traditional and complementary care or complementary medicine, the pharmacists and pathologists. So regional system, only states may be held accountable for human rights violation on regional system. In the states of Malaysia, there are a lot of states there, and that's the regional system. These systems do not prosecute individuals or decide individuals' responsibility for human rights violation. So, the regional human rights system engage in range of human rights monitoring and promotion activities, and regional human rights courts typically only receive complaints and do not engage in other monitoring or promotion activities. So, the hospital health system, when you do a program for the hospital health system, in Malaysia, it is a multicultural society and a secular state with Sunni Islam as the official religion. Therefore, the classification by World Bank as an upper middle income country, its society and economy were transformed by rapid economic growth in the latter half of the 20th century. Malaysia's population has been benefited from a well-developed healthcare system and good access to clean water and sanitation and a strong social and economic programs. As you can see, this is the cost of healthcare system. The condition treatment, public healthcare, and private healthcare. Uh, there have more than 25,000 to 80,000 ringgit for private healthcare on the cost of healthcare system, especially the coronary bypass surgery or cabbage. Chemotherapy is also ranging from 50 to 4,000 ringgits on private healthcare. A knee replacement surgery will cost you 25,000 to 80,000 ringgit, and one stent angioplasty will will cost you 15 to 45,000 ringgit. So as you can see, they're comparing dengue fever is free of charge, and a private will ask you 3,000 ringgit. Where would you go? Would you go to the programs of public healthcare or the programs and facilities of private healthcare? The based on the cost of healthcare system, and the operations and supply have to be structured on all healthcare system because they have to be standard. Whether you pay high or you pay none, the operations and supply must be there. The need, availability, and affordability, perceived quality, alternative choices, and administrative control. Efficiency has to be there, where the organization, selection, procurement, distribution, and the use of operations and supply are very important. So the necessity of integrated care, where hospitals needs to be integrated because everyone who checks in will have all their data in their health and circumstances stored in the hospital, and the hospital will then share with the family members as well as the people who will be caring for the care receiver, save on cost for both people and need care and the facilities that provide the appropriate services. Ultimately, an integrated care system is better off financially as opposed to care providers working in isolation, which makes the cost of services expensive. So the association, the APHM, or the Association of Private Hospital of Malaysia, it is more commonly known as HPHM, and this is just an association representing private hospitals and medical centers in Malaysia, which has been in existence in 1972 and currently has over 100 members throughout Malaysia. They are the ones involved in the program of facilities in private healthcare. So the members' role is to coordinate activities or programs, or the programs that private hospitals in Malaysia is conducting to facilitate the delivery of high standard or of healthcare to the public, and to promote the cooperation of individual hospitals engaged in providing healthcare services within Malaysia, and to promote cooperation amongst private hospitals with other providers of healthcare. So the public-private partnerships or partnerships and collaborations have begun to take form in an effort to cope with increasing healthcare demands and actualize the first steps of an integrated framework. And a good example is the Maisa Jatra, that is in partnership with all private places monitoring the health status of everyone in Malaysia. This is a program to have partnerships, you're private and you want to send message to the government who are positive, who are negative from the infection that is going all over pandemically. And this is a partnership where they scan the QR code, and when you scan it, you have found that this is a positive case, and they send the scanned cases to the government as a partner in order for them to identify who are positive, who are negative. And this is an example. It's not just only QR scanning for all the private institutions or private places. Also, they have um, they have these programs that you can register, okay, and they have a lot of special features wherein you can find clinics and find um, places to go to if you are sick. Pharmaceutical financing, on the other hand, in the Ministry of Health has developed an extensive network of uh, public primary care centers and also dental services, especially for children. Malaysia has a large pharmaceutical manufacturing sector that exports to the other countries and also supplies 30% of, of, of what they have. And the government has increased training places to counter shortages of health professionals, mystic demand, and the country is positioning as a medical tourism destination uh, in the long run. So this is an example of a program, vaccination program, that can help defeat the pandemic, and they're trying to vaccinate one of our prime ministers here in Malaysia in order for them to uh, defend themselves from the infection of the pandemic. Since it's a COVID-19 program of immunization, and this is one of the immunization programs that Malaysia is giving out for free to the public, to everyone. So, healthcare financing is defined as the mobilization of funds for healthcare allocation and of funds to the regions and population of groups for specific types of healthcare mechanisms for paying healthcare. So private health insurances, the Malaysian healthcare system is divided into two distinctive types, the public and the private sector of healthcare system. And workers from private and public sector are free to pay by themselves or insure themselves with any insurance agencies. So healthcare financing deals with generation, allocation, and use of financial resources in the health system. And globally, it has become increasingly recognized as an area of major policy relevance to achieve universal health coverages. So under this realm, uh, we have the healthcare financing division that supports evidence-based policy making and implementation and support the union and state governments in the area of healthcare financing with focus on health accounts, report and monitoring health financing indicators, and policy inputs. So Medicare does not pay for really significant amount of long-term care expenses. Medicare is a health plan. The Medicare will only cover nursing homes, homestay for people over, uh, for people 65 years old or older in very limited circumstances and only for a short period of time. Medicare is a long-term care benefit that works, and you need to have been admitted to hospitals for at least 3 days and then generally get sent to a Medicare certified skilled care facility under a doctor's order for care related medical condition. In some circumstances, this post hospital care can be provided at home. So the Medicaid become the default for long-term care. That is the Medicaid. And Medicaid covers many more types of long-term care costs for people 65 years old and older in nursing homes, at home, and in assisted living facilities. But most people don't qualify for it because their income or asset are too high. So the Medicaid program is run jointly by the federal government and state governments, so its income and asset thresholds vary depending on where you live. While the asset maximum for Medicaid may sound exceedingly low given the cost of nursing homes, assisted living facilities, and home care. Almost everyone has depleted their funds after a couple of years of long term care, says the grant of all those cares. So, Malaysia currently has a dichotomous public private system of healthcare services, and from what was largely a government led and funded public service enterprise since the time of independence, our healthcare service has over the decades transformed into a buoyant, dual tiered parallel system with a sizable and thriving private sector. There appears to be strong ambivalence as to whether to fully tap into the free market system for healthcare provision and funding or to resort to a single payer publicly controlled system where universal healthcare access is assured. So this is one of the largest sectors in the service department whereby the government provides almost all the all the infrastructure and the human resources, and doctors, nurses, pharmacists, dentists, and other allied healthcare workers are employed and deployed by the Minister of Health to various healthcare centers. And the distribution of these resources to various parts of the nation is arguably based on the size, need, and population of the various districts and states. So, the private healthcare expenditure, large Malaysian conglomerates, corporations, and companies were formed by medical specialists, including those involving foreign investors who have invested in private hospitals with government encouragement. And the private healthcare expenditure increasing tremendously over the years since the privatization policy was introduced in Malaysia. However, since the Malaysian government is a major investor in private hospitals, it is therefore not surprising for state agencies to support the growth of private healthcare and development of the health tourism. In tertiary healthcare services, they have the recently made presence felt in the Malaysian public healthcare sector beginning in the 1980s. Some of them have provided excellent specialist care for severally highly specialized medical disciplines, although these have added to the capacity to cater to the growing demands for tertiary specialist medical care and the problems of understaffing and staff poaching continued. So causes of the expert service to stall because the requisites or expertise has been lost. That is one of the purchasing private corporate sector expertise, and that's why public-private partnerships appears to be successful and beneficial, and attempts have been made to have it emulated. Healthcare privatization has been most vocal against any development towards the passing of any extra cost to the public. The full paying patient or the FPP scheme in Malaysia, where part of these fees were used for physician reimbursement to supplement their income allowance, is also an issue of the finances. Thus, this scheme provides those who are willing to pay more quicker access and shorter waiting time for elective surgeries and other therapies. While this is one mechanism to recover some costs for the healthcare system, it's only a minor fraction of what the system truly costs. So the health reformation to improve the health status of the population, to improve the responsiveness of health services of the population, and to improve the financial fairness or funding for the health system. In general, the available evidence demonstrates that the Malaysian health system achieves remarkably high and equitable health status in relatively cost, and the reform of healthcare should also aim towards both allocative and technical efficiency. So, allocation of resources within the Malaysian Ministry of Health is highest on the medical care, followed by public health services, which is 18%, and the finances on supportive technical and professional services and management is 15%, followed by Dasar Baru, or one of their programs, and management, and one of on other programs that they're doing is only 1% of their finances that being distributed. So that is it for the discussion of finances and also for the programs and facilities here on our topic. Thank you all for staying for this topic, and I'll see you on topic number 5. Bye. Hello, welcome back to topic number five, supply chain management. So, in this topic, we're going to discuss supply chain management and logistics and discuss variability in supply chain. So, what do you mean by supply chain? This is the sequence of organization and business process networks that are involved in producing and delivering a product or service. The chain of supply chain, sometimes referred to as value chains, as values is added as goods and services progress through the chain. That's why it's called a value chain. Now, the supply chain management is to structure the supply chain. You have to manage it and structure it so as to maximize its competitive advantage and benefits to the ultimate consumer. So, the logistics here is the part of supply chain that involve activities, transportation, warehousing, packaging, etc., that move and position inventory between the point of origin and the point of consumption. So, what's the key difference between supply chain management and logistics? Supply chain management is always a way of linking major businesses. This is the managing of the processing within the and across companies into a high performance business model. You're just managing it. And logistics refers to the movement, shortage, and flow of goods and services and information inside and outside the organization. That's the difference between the two. The main focus of supply chain is competitive advantage. And the main focus of logistics is meeting customer requirements. So what is your requirement? What's your competitive advantage? So they go together as one, but they are separated. Why so much interest on supply chain management? Number one, as manufacturing becomes more efficient or is outsourced, companies look for ways to reduce costs. And several significant success stories like Toyota or Dell, they have efficient supply chain management that gives an important edge. And the web-based model for supply chains are the online retailers and B2B business models, okay? Back-to-back business models. So, supply chain costs, for example, vaccines, when you're trying to make programs, it's like 67% purchases of supply chains and mechanical ventilators. You're giving facilities for those who are in the intensive care or emergency care. Chemicals that you need to procure for developing new drugs, or you're trying to make your own clinical trial of a drug. There's a chemicals involved. Food, of course, you need to supply food for the workers if you have a program. Intravenous fluids, syringes, paper, needle, trolleys, ambulances. All these are supply chain costs. These are examples of supply chain costs. And a customer that are requiring product services appropriately will have the chain. This chain will show you how complex it is. It's not just going down the slope until you reach on the far end there as received, as promised, but there are chains that can happen all throughout those supplying. So from the customer's perspective, 88% satisfaction is happening and the customer satisfaction is high. So you have to meet the price and delivery requirement. You have to see the customer order and produce as promised and receive as promised. This is what you promised them. This is what they need to receive. That is what you call the perspective of supply chain performance. And product design, product planning, sales, manufacturing, and distribution are very important on managing your supplies. And therefore, terms used to describe the different parts of the supply chain from second tier supplier to first tier supplier into the supplies, and then first tier customer, second tier customer, until the end customer happens. It's all terms used to describe the different parts of the supply chain. Purchasing and supplying management is more important than physical distribution of management. That's what the mentality of all our hospitals have. Like, this is my purchase and I want to physically distribute it. I need to have the money first before I can distribute. That's the first mentality. Material management and logistics happens, and the supply chain management has the inflow and the physical flow. So in internal and external supply chains, the second tier hospital, the second tier suppliers goes to the first tier. That means the first level. The second level supplier, those are the one who are giving commissions, are taking all those marketers, those taking consideration of all the marketing distributions, and they're taking all those second tier suppliers, and then they're giving the first tier supplier from the original supplier, and then they go to the operations, and then they go to the first tier customer, second tier customer, until they reach the total supply network. So the immediate supply network is very important in internal and external supply chains. So this is how the operation works. And now, these empty boxes are just a figure, an illustration of operations performance, and should be seen as a whole supply chain issue. And the benefits looking at the whole supply chain includes putting the operations into competitive context, helping to identify key players, shifts emphasis to the long term, sensitizes the operation to macro chain changes, and changes the nature of the supplier buyer relationship. So the supply chain management objective is definitely all supply chain management shares one common central objective to satisfy customer. And when a customer decides to make a purchase, he triggers action back along the whole chain. And all the businesses in the supply chain pass on portions of that end customer's money to each other, and each retaining a margin for the value it has added. It does by supply chain strategy alignment, aligning supply chain distribution strategies, designing on need for outsourcing and network configuration, and to determine the number of location of suppliers, warehouse, production, operations facilities, distribution centers are very important in managing supply chain. So, as you can see, corporate strategies impact supply chain decisions, and primary supplier selection criteria is so important as it goes to the cost and response strategy and differentiation strategy. So, the next is the supply chain inventory. It minimizes inventory to hold down costs, use buffer stocks to ensure speed supply, and minimize inventory to avoid product obsolescence. Therefore, the distribution network is inexpensive in the transportation because they sell through discount distributors, retailers. You should have all those distributors, retailers, and discounts. And fast transportation is the response that should have in provided premium customer service and gather and communicate market research data, knowledgeable sales and staff. And the product design characteristics must maximize performance and minimize costs. You have to have minimizing costs, and don't throw away some products that can be recycled, except for syringes and needles. You have to throw it away. Those are the things that you need to not minimize costs, but some other minimizing costs, such as um, pans, you can recycle IV fluids, cut them all together, and cut them all off into half, and use that as urine collections. You know, when you want to throw away the urine, but measure it first because the IV fluid has measurements. So those are the things that you have to minimize cost. Low setup time, rapid production ramp up, modular design to aid product differentiation are all on corporate strategy impact on supply chain decisions. So what is the benefit of supply chain management? You know, you have to have a benefit of supply chain. It reduces uncertainty along the chain. Of course, you have uncertainty of how much did we lose, or any expired products here, any cotton balls that has been expired, or do we have enough gauze to do the wound management. Proper inventory levels in the chain, minimize delay, eliminate rush, unplanned activities, and provide good customer services. So how do you do all these? These are the benefits of supply chain management. The activities of supply chain management is purchasing and supply chain. The logistics supply or the physical distribution of the management of the supply are very important. The activities of supply chain management are purchasing, supply management, purchasing, buying materials and services from suppliers. They must understand the requirement of the operations and the capabilities of the supplier. The supplier initial vetting evaluating the sources of supply in terms of price, quality, delivery flexibility, financial stability and services, and the supplier certification. It involves a detailed examination of supplier's policy and capabilities to meet the requirements of a buyer. And there are also the supplier periodic audits to ensure that the supplier are continuing to perform up to mark in terms of quality, delivery, and problem resolutions. So, relations between operations and supply chain have the calculative trust, cognitive trust, and bonding trust. The based on knowledge and based on feelings. So, they have this degree of trust. Partnership relationship are seen as desirable because they can reduce the transaction cost of doing business when you're doing supply chains or supplying the programs of your public health or your healthcare. Factors for rating suppliers: number one is the range of product or services provided. Are you having a potential for innovation of the range of products or services provided? Is the quality of products or services have ease of doing business? Is it broken, expired, or are the material damaged? Responsiveness, willing to share risk, and dependability of supply, long-term commitment to supply, delivery and volume flexibility, ability to transfer knowledge as well as products and services, and the total cost of being supplied, technical capability, and ability to supply in the required quantity, which is the operations, financial capability, and managerial. So, relationship between operations and supply chains. Number one is the trust. Do you trust them? Can I trust you with this? And sharing success, because if you have um, testimonies, you can do so by sharing the success. Multiple points of contact, few relationships, information transparency, dedicated assets, joint problem solving, and joint coordination of activities are all under these partnership relationship. Long-term expectation and joint learning are also partnerships. Partnerships, relationships, and desirable are desirable because of their closeness of relationship to the partners that they have. So the supply chain management, logistics, physical distribution management is divided into transportation, storage, and warehousing. You know, where do you there are some strategies in the hospital where it first in last out, or first in first out, or something like that. First in last out, last in first out. That's how the storage is on hospital keeping an appropriate amount of inventory of products so that they can be delivered to the next stage in the supply chain. Warehousing is providing suitable accommodation in which to store inventory, and this involves deciding on the location, capacity, and capabilities of the warehouse operations. So we have storages in hospitals that can be called warehouses. And the transportation physically is the moving of products. So that is the activities of supply chain management. Another activity is material handling, ensuring that the movement and storage of products or materials is handled efficiently. And this involves choosing appropriate materials, handling technology, and organizing warehouse staff jobs for efficiency and safety. So the security is protecting items from damage, theft, and provide suitable protective packaging and security measures such as locks, security cameras, the GPS trackings, and or those other securities. Other processing and communication is vital that the location and condition of the items are communicated well to all parties in the supply chain who need the information of their own planning purposes. So the relationship between operations and supply chain is found on this figure. The factors influencing the nature of work network relationship or the networks of operations, resources, and market requirements have all these transactions. They have transaction costs, economic sales, market position, market risks. So do you think you'll have um, a lot of market for this? Market structure, competitive behavior, resources deficiencies, and learning potentials are all nature of network relationships. So what are the variability in supply chain? Number one variability is the demand variability. So even the most sophisticated demand forecasting tools often fail to anticipate demand, they have the variability in supply chain. The next is the process variability. So production unit downtimes and unexpected staff absences of process variability is very important. Who will process this? Who will distribute if only one person can do it? Supply variability, this is the late deliveries from suppliers. And the lead time variability, the longer the lead time, the slower the response to changes. So the potential supply chain risk are more reliance on supply chain means more risk, fewer supplier, and increased dependence, compounded by globalization and logistical complexities. The vendor reliability and quality risks is also a potential supply chain risk. And political and currency risks are also supplies. What if the economy fall down, and there are more prices that are going to increase? They are the risks of currencies. So managing the bullwhip effect. What's the bullwhip effect? They have the cause and remedy. That's the bullwhip effect. So the cause, because the demand forecast errors or cumulative uncertainty in the supply chain, you have to share demand information throughout the supply chain. And because of ordering batching large infrequent orders, leading suppliers to order even larger amounts, you have to channel coordination and determine lot sizes as though the full supply chain was one company. And because the price in fluctuations buying in advance of demand to take advantage of low prices, discounts, or sale, you have to stabilize your price every day low prices in stabilization. And because of shortage gaming or hoarding supplies for fear of supply shortage, you have to allocate orders based on past demands. Okay, so look at the past demands and see which one is the most marketable that you can have to manage as a supply. The issues of doing supplies like forecasting, um, product quality, product packaging, pricing, speed, distribution costs, and inventory, they have forward logistics, such as the relatively straightforward or the uniform product quality. It has to be uniform, all qualities. You can randomly pick anything and its quality is high. Product packaging, everything has to be packaged in a uniform. Not everyone, not sometimes big, sometimes small, sometimes poor packaging, sometimes good packaging. And the pricing is relatively uniform. Often very important, they are easily visible, and the inventory management is consistent. So the reverse logistic is more uncertain on forecasting. How can you forecast? How can you see the future? They are more uncertain. Uncertain in the reverse logistics, they are not uniform. That means sometimes they are they are poor in quality. Sometimes they are good in quality, not in uniform. Product packaging often damaged. The packaging is damaged, and pricing is dependent on many factors. They are not just only one. They don't have the relative uniform pricing. It depends on you. So sometimes the challenges is, how can you have a good supply chain management if you don't know the pricing that is standard? The speed is not often the priority because sometimes packaging and also supplying is slow based on the current situation. And distribution costs is easily visible, but on reverse logistic, they have less directly visible. They are directly visible. Inventory management is not consistent as well. Sometimes you have a good management, sometimes you don't have a good management. So, need for benchmarking the supply chain. Example: supply chain metrics in the consumer packaged goods by industry in the United States. Just let's just look at the United States. Sometimes they are order fill rate. Typical firms are 71%, and benchmarking firms are 98%. Order fulfillment lead time in days is 7%, and benchmarking is 3%. Cash to cash cycle is 100%, and benchmarking is 30%. Inventory days of supply is 50%, and benchmarking is 20%. So export packaging, you sometimes there are some supplies that cannot be found in Malaysia. So you need importing and exporting. And if you want to export packaging, 6 month savings must have because of innovation. Supplier innovation is very important on uh, export packaging. So that's it for our topic number 6 and topic number 5. And thank you very much for staying. See you on topic number 6. Bye. Hello, welcome to topic number 6. This is the Global Health Service System, and the objective for today is to discuss global health and discuss overview of healthcare in Malaysia as compared with global system. So what is global health? Um, Precisely, global health definitions vary by sources. It can be thought of as the understanding of healthcare at an international or interdisciplinary level, and it includes the study of research and practice of medicine with a focus on improving health and healthcare equity for populations worldwide. While World Health Organization defines global health as one of the most prominent agencies advancing global health researchers and leaders in a variety of fields that are spearheading initiatives to work together. To work together is global health workforce. So, um, 6 prominent global health issues to be aware of. Number one is the pandemic. Okay, global health disease outbreaks such as influenza, COVID-19, etc. Many of which originate in animals. And number two is the environmental factor. Storms, flooding, droughts, and air pollution make it easier for disease to spread across large groups of people. Economic disparities in access to healthcare. They're the result of income inequality, with individuals and families simply unable to afford healthcare that is otherwise unavailable. The political factor, which is the conflicts within or between nations to destroy critical infrastructure, average citizens become more vulnerable to diseases. And the non communicable diseases are the heart disease, stroke, cancer, diabetes, and other non communicable diseases that accounts for 70% of all deaths worldwide, according to World Health Organization. And animal health, food sourcing, and supply are also one of the 6 prominent global health issues to be aware of, such as the agricultural practices, including irrigation, pesticide use, and waste management. They can include animal health, making disease transmission a concern at every stage of the food supply chain. So, in New Zealand, a consensus developed in New Zealand that government has a fundamental role in providing for the population's healthcare needs. No citizen can be denied treatment in public hospitals, and all citizens have insurance through government funds, universally accessible health services. In practice, however, coverage vary by income, need, location, and type of services. And the primary care is mostly free for children ages 13 and under, and is subsidized for the 98% of the population enrolled in networks of primary health organizations. So the patients who have had more than 12 GP visits in a year can apply for a high use health card, which reduces the amount they owe in copy payments and co-payments, and low income people can also lower their co-payments by seeking a community service cards. So this is the healthcare service system in New Zealand. The healthcare service system in the Ministry of Health of New Zealand, which has overall responsibility for health and disability system, acts as the Minister of Health's principal advisor on health policy and maintains a role as funder, monitor, purchaser, and regulator of health and disability services. So the Technology and Digital Services business unit within the Ministry of Health is responsible for implementing the government's digital health strategy and other e-health initiatives. The Capital Investment Committee, which is Ministry of Health subcommittee, advises on matters relating to capital investment in the public health sector in line with the government's service plans. And Health Workforce New Zealand leads and supports health and disability workforce training and development. So this is the New Zealand partnerships, pharmaceutical management agencies, the Health Quality and Safety Commission, the Health Promotion Agencies, and Health Research Council. The publicly funded system covers the following services: preventive care, inpatient, outpatient, primary care, maternity services, physical therapy, durable medical equipment, inpatient, outpatient, medical care, dental care, long-term care, home health, and hospice care and disability. So in Brazil, another healthcare service system in Brazil, in global, all residents and visitors, including the undocumented individuals, can access free, comprehensive services, including primary, outpatient, specialty, mental health, and hospital care, as well as prescription drug coverage. The Ministry of Health is responsible for national coordination, including policy development, planning, financing, auditing, and control. And the state government duties include regional governance and coordination of strategic programs such as provisions of high cost medicines and delivery of specialized services that have not been decentralized to municipalities. And the health departments in the 5,570 municipalities largely handles the management at local level, including co-financing, coordination of health programs, and delivery of health services. So, organizing of the health system in Brazil is found on the federal government, state government, and municipal government. The Tripartite Intermanagement Committee, or the CIT, they are also doing the state government. Bipartite and Intermanagement Committee is also doing the state government in Brazil. So this is how complex their health service system is globally. And globally, broad spectrum of health services free charge, including preventive services, including immunization, primary health care, outpatient specialty care, hospital care, maternity care, mental health services, pharmaceuticals, physical, dental, optometry, and other vision care, durable medical equipment, including wheelchairs, hearing aids, home care, organ transplant, oncology services, renal dialysis, and blood therapy. In Canada, all citizens and permanent residents receive medical necessary hospital and physician services free at the point of use. At the national level, a variety of governmental agencies oversee specific functions such as Health Canada, which is Federal Ministry of Health, plays a key regulatory role in food and drug safety, medical devices and technology review, and the upholding of national standards for universal health coverage. The Public Health Agency of Canada is responsible for public health, emergency preparedness and response, infectious and chronic diseases control and prevention, and health promotion. And a new federal government department, Indigenous Services in Canada, funds certain health services for First Nations and more. So this is the health service system of Canada, the organizational health system in Canada. They have Canadian Constitution, the federal government, the Ministry of Health, Canada Health Act, and provincial territorial governments, the Ministry of Health, and federal provincial territorial conferences committee, and regional provincial territorial health authorities. They have collaborative contributors of multiple pan-Canadian organizations. This is how the complexity of health service system in Canada is. In Italy, Italy's national health services automatically covers all citizens and legal foreign residents, and residents receive most free primary care, inpatient care, and health screening. Other statutory benefits include maternity care, specialty care, home care, hospice care, preventive medicine, and pharmaceuticals. So the health agency ministry includes the following: the Ministry of Health oversees healthcare planning, such as determining the essential benefits of packaging, and National Committee of Medical Devices for medical devices develops cost-benefit analysis. The Agency for Regional Health Services, the sole institution responsible for conducting comparative effectiveness analysis, which is accountable to the regions and to the Ministry of Health, and the National Pharmaceutical Agency, which governs prescription drug pricing, reimbursement policies, and all other matters related to pharmaceutical industry. The Organization of Health system in Italy, this is the parliament, the government, and goes down further into the local and private pharmaceutical general practitioners, private accredited hospitals, and private accredited specialists. So these are the organization of the health in Italy. Overviews of Malaysia's healthcare system. So when we try to see the healthcare system of Malaysia, Malaysia provides universal healthcare for all citizens. In comparison globally, we also have provisions and legal residences providing healthcare services. The government of Malaysia heavily subsidizes the cost of care through public facilities, and the subsidized public healthcare system and a well-established private system work well in conjunction with each other. And there's no public health insurance program for expats in Malaysia to join, and there are some options for international citizens living in Malaysia as long term to have their health insurances. In tourists, Malaysia can use public healthcare facilities if they need to, but they'll have to pay for the services that they receive. So the challenges and the changes, given that the rural area are sorely lacking adequate healthcare facilities, the government has committed to improving and expanding the telehealth program that connects rural patients and doctors, and the government is also looking at ways to refurbish existing hospitals, build new ones, and expand the number of clinics in rural areas. With rural and vulnerable patients in mind, in 2011, the government launched a program called Medicine via Post to renew prescriptions through the mail and designed first and foremost to help patients with chronic diseases. And Medicine via Post is growing and has the potential to transform care for many patients. The government is also working on an initiative called Community Clinics, and formerly known as the One Malaysia Clinic, formerly known as the One Malaysia Clinic. Now, this government-based clinic has nearly 400 locations that offer free and nearly free care for all citizens. Additionally, it offers heavily discounted prescriptions and medications if such clinic could expand across Malaysia, including the rural areas. So that's the global healthcare, and thank you very much for staying for this topic number 6, and this ends the topic for the entire session. Uh, these are the references, and I hope you enjoyed the 6 sessions. Bye.